some of the basics from last week. Okay, so if we're talking about normal puberty, just normal run-of-the-mill, normal puberty, what is the normal age range for females? 8 to 13, not males?
9 to 14.
Yep. First true sign of puberty in boys.
Testicular growth.
If you had testicular enlargement in a 5-year-old male, what is that until proven otherwise?
Cancer.
Brain tumor, yes. Let's see. First line treatment for dysmenorrhea. Second line treatment. Yeah, your hormonal contraceptions. Can children with untreated seizures be active in sports participation?
No.
What are your other untreated seizures? Untreated, so no. What are your other contraindications that you would say no?
Splenomegaly.
Splenomegaly from what? From mono.
Mono.
For how long?
8 weeks.
1 month, 28 days. For active mono, for that contact sports. And then what's the other? Untreated seizures, mono with the splenomegaly, one more of, this is not Marfan. If you're doing a pre-participation sports physical, what in the cardiovascular system? What
Holcomb?
vital sign? Hypertension, what stage of hypertension? Stage 2, untreated hypertension. Good job. No, I saw someone now.
Oh, okay.
No, I was saying it back there. So. I saw you. Yeah. Yes. So those were the big 3 that should be a little bit harder to remember for those ones. Okay. So we're going to do a couple of things today. We're going to finish up block 1. So all of this normal and abnormal is what's in prep to talk about child abuse today. So it's going to be really helpful in learning your developmental milestones, of which you will need to know for Friday. All of those, what is normal and abnormal at the different ages. We'll talk about some child abuse. We're going to take a little bit of an earlier break. Someone stop me at like the 40-minute mark. We're going to take a little break and then we'll finish up. And then at 2:30, I've asked the child abuse specialist from Fancy to come over to talk for a couple of different things. Number 1, what resources? Number 2, when and how can this person help you as a primary care provider? And then 3, to kind of just talk for a couple minutes about his experience in this particular field. So this is a subsection of pediatrics, so you do 3 years in a pediatric residency and then another 3 years in a child abuse fellowship, specifically for this. So things that it would be helpful to just have a little bit of an expert's opinion, change the day up a little bit, a new face, maybe you'll remember it differently. So child abuse. When we are talking about child abuse in general, this is one of those really unfun parts of medicine. There's a couple of other things. I don't know if Dr. Love has done her intimate partner violence one. Those used to be on the same day, and that was a good time, when you had 4 hours of different types of abuse. But these are these unfun things that because you've chosen to go into this profession, as of today, after you are getting briefed on it, you become a mandated reporter. So if you see something, you have suspicion of something, it becomes something that you have to do something about. So we're going to talk about different types of abuse today, physical, sexual, psychological, emotional, and go over what to look for, what are some of those red flags, and again, the preponderance of the evidence and looking at suspicion. So when we're talking about this, again, epidemiologically, we are looking at anywhere from 1 to 2% of children are experiencing this at any given time. If you think about how many children is that, well, that's about 3 million reports annually. That's a lot of children where something is going on that shouldn't be going on. That's just the reports though. So when you're thinking how many of these are validated every year it's about 1 million. So 1 million children every year, and that's leading to anywhere about 1,500 deaths. That's why pediatricians jump up and down, is because abuse counts for a lot of the mortality that we see with this, and not to even mention the morbidity. If you're looking at the statistics, Most of the time, mothers are going to be, or primary caregivers are the ones that are directly involved in abuse. A lot of times mothers are more likely to be the abuser because the most often type of abuse you see is going to be neglect. So it's usually where mothers come into play. Physical abuse is usually going to be the male partner in a relationship, a father, mom's boyfriend, somebody that is close to the child. That is typically physical abuse, especially serious abuse, much like head and abdominal traumas. So we're thinking about who is at risk for this. Some of these should make sense to you. Parental issues. So certainly if there are drugs in the house, any kind of financial strain is going to increase the likelihood that something's going on. A person's mental health, if they already have something going on, they're more likely to potentially have a violent streak. The other one is if there is domestic violence in the house or in their growing up, an increased likelihood. If you're looking at it from the child's perspective, so certainly we had talked about that a couple of lectures ago. If you have children with special needs, they're requiring even more attention, even more resources. So sometimes kids that need additional things are at a higher risk of that. Adopted children, stepchildren, and premature infants. The thing that all of those have in common that you see correlating, not as a causation, but as a correlative factor, is that there was something that's impeding the maternal and paternal caregiver and child bond. So did they not have it right away? Was there something in those first few days, weeks, months, or even years where the bonding was impacted? And then the social support. So if we're thinking about this in military terms, we have people that are moved away from family, young parents that don't have necessarily the social support, deployments, frequent PCSs, things that are going to contribute to the increased likelihood of abuse. The different types, again, I said most common is going to be neglect. And neglect can come in all different forms and fashions. So this could be something that the child needs that it is not being provided for. And very hard to document, a lot of times hard to prove. If I'm going to ask you something like that and all the questions on the pants, it is very straightforward. So think if you're not being fed and you have complete absence of that and you're neglected, what are your growth charts going to do? You're going to plummet, right? So you're going to see that failure to thrive or the growth faltering. Certainly if they come in and they are not in appropriate clothes for the season, that could be an indication where you have some sort of neglect. An emotional neglect, very, very hard to document and prove on that, but probably one of the things we see often. What might medical neglect look like? Yeah, they come in, a weird story, they don't come in. I've had a couple of patients, they make and cancel appointments like 6, 7, 8 times, right? Makes sense once or twice, oh, we forgot an appointment, the car broke down. Does that make sense if it's been 6, 7, 8, 10 times, right? That doesn't make sense as much. The other one that I recently saw that was kind of interesting, I really hadn't seen that, was educational neglect. So this child, I think was in 2nd grade and had like 57 absences. The parents just like didn't take him to school, didn't homeschool, didn't do anything. And so the child couldn't read, didn't know their alphabet. So you have an educational neglect. The physical abuse is often going to be termed non-accidental trauma. And that will actually be your diagnosis. So you'll hear NAT. Non-accidental trauma is saying something happened and there's a form of physical abuse here. It's going to be the most common. And that's kind of what you think of the standard, quote-unquote, abuse is going to be, where there's some sort of physical abuse involved in this. Again, this one is primarily someone very, very close to the child, a primary caregiver or someone who is directly related to that primary caregiver. So the classic question is always mom's boyfriend. If you see mom's boyfriend in a question stem, they're asking you some type of child abuse, and usually a physical abuse. Okay? It's the only time in a question stem you see mother's boyfriend. Again, we said emotional is pretty hard to document, but it's something that's going to kind of mess with that psyche of a child. So you have some verbal abuse. You can have witnessing of abuse in the home. That can certainly be a different type of emotional abuse. So we don't talk about that as much. Some behavioral indicators. And then we won't perseverate for a long time, but sexual abuse, anything where there is something that a child cannot consent to, child is unable developmentally, there is an age mismatch, there's all kinds of different things that sexual abuse can be in violation of. So we'll talk about some of those. And then the classic, so it used to be called Munchausen syndrome by proxy. So they're fictitious disorder imposed by another. So the parent is making this up for the child and saying that there are things wrong that there are not wrong. I had a patient with this, the parent, I got to my new base. This child had colonoscopies, endoscopies, x-rays, labs, hospitalizations, just time after time after time. The pediatrician before me was an excellent pediatrician, fantastic, and it kind of had slowly started to ramp up over time, so fresh eyes could see something new. Anyway, as this kind of peeled back and rolled back, it had ended up and started because this family had twins, and dad was really disengaged, was a new commander, was really kind of on a fast track with his career, and the only time that mom really got dad to be engaged was when one of the babies was in the hospital for a neonatal sepsis workup. And so that seemed to trigger something of, he's part of the family when something's wrong with this child. So she started just making things up and doing things and having the child have different procedures where you couldn't really even document it. And so eventually it all came out. But this happens in real life. This happens from things that you wouldn't even necessarily quite put together. But this was in our military population. So Dr. Hatch, who's coming in, has a lot of different experience with that particularly. But good, interesting documentary if you want to see fictitious disorders. There's a documentary, I don't even remember what streaming platform, about Gypsy Rose. That's fictitious disorder imposed on by another. So what does that look like to the nth degree? Again, you want to watch something and call it studying, watch that. Okay, start this one. Red flags for abuse. Things that you can say, this doesn't make sense. So if you have a significant injury, this child comes in, burns, bruises, bleeding, broken bones, some sort of significant injury, and you ask them what happened here, and they're like, I don't know. And they just have no story. None. No story. So that, nothing happened at all. So that's going to be a big red flag. Changing history. So if they come in and they tell your MA one thing, they tell the triage nurse another thing, they tell the medical student something else, you something else, the attending, so there's real-time changing of the story, big red flag. History is inconsistent with the injury. So if somebody says, yeah, I just stepped off the curb wrong, and this kid is just kind of clumsy and stepped off the curb wrong, and they have a fractured femur, right? That doesn't make sense. Inconsistent with the history. Repeated injuries. If you see somebody say, this kid is just really clumsy, and they just hurt themselves all the time, really, really clumsy, and have a history that doesn't sound normal like that. This is where the developmental abilities come into play. So if it doesn't match your developmental abilities, so if someone came in and said, yeah, my 2-month-old just rolled right off the bed, just kept rolling right off, that should make your flag go up to say, ooh, 2 months old, you shouldn't be rolling. That doesn't make any sense. So your story doesn't match. So do you have something that on exam where you have a cerebral palsy-like situation, or is this really a case in which they developmentally do not match with this? What's going on with the family? Is there an acute crisis going on? Is there some intimate partner violence or a recent deployment? Something that the family has some sort of crisis going on? An unreasonable or delay in care. So other than the snowpocalypse, there really shouldn't be a reason that you wouldn't have your child get care in San Antonio. If they said, oh, the weather was just so bad, I couldn't get here for 3 days. Right? That doesn't make sense. That would be a red flag of something in this story doesn't make sense. And then inappropriate affect of a caregiver. Most parents are going to act how when their kid is hurt or injured? Distressed, distraught, right? So if you have something where they are histrionic and over the top, or if you have somebody who's just playing on their phone, doesn't give a care in the world, could be another red flag. Something is inappropriate, a mismatch in that affect. Some of the complications of abuse. So we always say it very succinctly, right? Hurt people hurt people. So if you're thinking about if this child is hurt as a child, you're more likely to see them be a violent adult. So it's going to be one thing that you see. Having trouble with different types of relationships. So this might be, I have trouble in my romantic relationships as an adult. Or this might be, I struggle at school as a child and I become the bully. Or I get bullied, right? I really struggle with these different relationships. Sometimes mental health, depression, anxiety, more likely to have sleep and substance abuse because they're trying to kind of self-medicate some of the things that they don't understand as a child. When you're interviewing these children, some things to think about. There are different cultural and ethnic considerations that we'll talk about. So some of the things on your differential should come to mind of potentially things that could be something that we would see. Not blaming, so don't pick that as an answer this week. Don't say blame the parents. It's not the right answer. Okay? You don't even need to confront the parents. This is where truly doing a physical exam and being very objective. What am I seeing? Am I seeing bruising, bleeding, scarring? Just very objective. What am I seeing and documenting that? Remember, a lot of times it's the primary caregiver, but a third of the time it's not. So if you're accusatory, a lot of times you can break down that relationship where then you've lost any kind of therapeutic relationship. Not showing frustration is very, very difficult. So if you know something not okay is going on, and that is a very, very hard thing to not do, which is where that last one comes in. I would encourage you, if there is any type where you are concerned for an abuse situation, bring a chaperone into the room for you, the provider. Right? That's a second set of eyes of someone else in that room that heard how the dialogue went, could see what you were seeing. So that chaperone in that case is really there to protect you and your practice. And then always assessing, is there a level of cognitive impairment for both the patient, we might put them at that increased risk, special needs, or does the parent have a cognitive impairment? Because that could be a contributing factor as well. So it'd be the one time that I would say if you're interviewing that you truly do ask a child open-ended questions or the parents open-ended questions. I think every single class you've had has said that. Ask open-ended questions, and then we're like, but really direct them and target your questions or you will be there all day. This would be one of the times where I would say really open-ended questions is going to be very, very important. If you can, asking the child in a situation where they do have the freedom to talk to just you. What type of exam was that if you were in a adolescent situation? You're doing the advanced social history. What was that exam called? The HEADS exam. Yep. So essentially doing a HEADS exam for those adolescents. If you have a caregiver who's I'm not leaving the room under any circumstance, again, that doesn't necessarily mean abuse, but that could be another red flag that there's that inappropriate affect there. Parent and child interaction. Most kids are really comfortable around their parents, or even they're comfortable being little brats to their parents sometimes if they're teenagers. If you see a really weird interaction where the child is going to you sometimes for comfort and not the parent, or the teenager looks like they're really scared around the parent, something to pick up on in the room. Again, does your mechanism correlate? That can matter. And then the perfect rolling off the bed example, I think that's probably the classic one. If you see that on the test question, remember your developmental milestones. Is that something that this child could even be able to do? Right? If they couldn't even be able to do it. Another example we talked about earlier in this block, if the child was losing teeth really early, does that make sense? Are they supposed to be losing their teeth at 3, or is there some sort of physical abuse that's going on? So some of those developmental things will be very helpful. These are just some questions in general, nothing that you need to zone in on particularly. The ones that I would say that I use the most often is probably, what do you do if something's bothering you, right? Or do you feel like you have an adult that you could go talk to? Or what do you do if something's bothering you? And then, do people fight at home? So that's a really good question to really assess what is going on in that household. So do people fight? How do they fight? What do they fight about? Sometimes that can give you a whole lot of information about what's going on for that child. For the adolescents, this is functionally that HEADS exam. So a little bit more risk stratification. I will sometimes ask specifically, do you get in fights, or have you had somebody try to fight you? When's the last fight you were in? And then I think we talked about the weapons. Do you have access to weapons? Do the weapons have ammunition? Do you carry a weapon on you? So something to ask specifically. And then for the parent, a lot of times in cases where there is domestic violence in the house as well, I think the classic one that we've all heard and asked in the military 1,000 times, you're like, any abuse at home, do you feel safe at home? and then somebody looks at you right before your dental visit and you're like, even if you were totally terrified, you'd be like, I'm fine, right? That's just not conducive to that at all. So sometimes pulling the parents aside to say, are you frightened by your partner? Does your partner ever threaten or hurt you? Could be a very important question. I had another story of a child, the child was fine, was there for a well visit. I saw him at the 2-month and then the 4-month, and the mom's depression score through the roof. Really weird interaction between the dad and the mom in there, and I should have, and this little voice kept saying, pull mom aside and ask her specifically if she is okay. And I asked her, I didn't pull her out, didn't pull her aside, and anyway, that father ended up abusive head trauma and shaking the baby, and baby did survive, but had subdural bleed and some retinal hemorrhages and hearing loss. And mom later said he was abusing me too, and so I couldn't tell you in that room, so I just started scoring as high as I could and missed it, right? So that was on me of missing this. So if you get that spidey sense as a provider, something doesn't seem right, take the extra time to pull them out and ask the kid by themselves or a parent by themselves. Because later on, when you're looking back, you're like, should have done that. So learn from my mistakes. Okay, we're going to talk about the specific different types of neglect. So again, this is when something is being omitted from those basic clothing, food, shelter, security, safety, medical, and then education is the one that I recently added on there after seeing 57 absences. I don't even know how many days are in a semester, but that is impressive. 57 times. So could be of any of this. Again, most common form of abuse is that some sort of care is just not being given, and sometimes these can compound on each other. Very variable depending on what is being withheld from this child, so that should make sense. A lot of times you're going to see this as that failure to thrive or growth faltering, which is why growth charts for every visit are very, very, very important. We're going to look at a couple of different types. Most common type is going to be that wasting type. So what was type 2? Do you remember from that earlier? You had type 1 that was wasting, type 2, and then type 3, growth faltering. What was type 2? Where you don't have the length. Yep. What's that called? Stunting. Yep. So your type 2 is stunting, and what was your type 3 growth faltering? Symmetric. Correct. Symmetric growth faltering. So most likely though, in this situation where you have neglect, you're going to see type 1 of just wasting where the weight is involved. Sometimes the kids will end up having some sort of self-destructive behaviors where you're especially evident at school many times. They could be begging or stealing for food or becoming kind of little kleptos. They're trying to get what they need any way that they can. You might see this as a child that is very, very tired in school. So they are in a non-safe environment at home. They feel safer at school. That's where their cortisol drops. So they're constantly fatigued and falling asleep at school. Assuming adult responsibilities are concerned, that's called parentification. So sometimes you'll see this where you'll see the 6-year-old is taking care of the 3-year-old, and the 6-year-old's making macaroni for the 3-year-old and really acting in that parent role as opposed to the child role. So if you see parentification there, it could be an indication that something's going on. No caretaker at home. I'll show you a picture of potentially what happens in this. And then again, if you have a parent that's not engaged at all, just really no connection with that child's sign that there could be something going on. So in this child, this is a little child who was left in their crib, left with a bunch of bottles, with one diaper. Parents would leave for work and then just come back at the end of the day. Okay? So on exam, when you're seeing this child on exam, a couple of things are noted. What are you seeing on exam? This picture. So dermatitis. Yep. What region?
The diaper.
Yeah. So what's your diagnosis? Diaper dermatitis. So diaper dermatitis. Yep. What about the size of this kid? Really plump, small, skinny?
Wasting.
Yep. What about the size of the head though? Is that still normal? Yeah. So the head's normal. You can see the baby's growing in length. This is that classic type 1 wasting, where loss of weight, but the length in the head is preserved, and you're seeing specific dermatitis in a consistent region. So this would be an example of where you have medical diaper dermatitis, right? Because not every most diaper rashes are not from neglect, right? You have a diaper dermatitis secondary to neglect in the setting of type 1 growth faltering or failure to thrive. So there's a lot going on from one picture that you can see. A warning here, when we're talking about all of this, every semester there's some times where this triggers some things in people, and so if you need to step out or dissociate for a little bit, that's totally fine. Come back in, talk to me after class. But I warn you, there are some difficult pictures in the rest of this lecture. So, when we're talking about physical abuse, that somehow shows up on their exam or something from your labs or radiology. So one of those classic forms, your history does not match. So if you had a child with all of these bruises and they just tell you, oh, we were just playing on the floor, like that doesn't add up. So something was inconsistent with that. You pick this up on routine exams. So if this child came in because they had a cough and a runny nose, and you saw this on exam, this now becomes your most pressing priority. They're probably going to be just fine from their cold, but you did your surveillance exam, not your screening, but your surveillance, and this now becomes the priority. Bruising, we're going to talk about when do you use the stages of bruising and how accurate is that or not. We're talking about location, so different areas are classic for abuse versus not. So fleshy areas where they're like sourdough bread babies, right, are places where you should not see bruising. So babies' abdomens, you shouldn't see bruising there. Babies' buttocks, you shouldn't see bruising. Cheeks, any place where it feels kind of like sourdough bread, you shouldn't see that. Bony prominences in a mobile child, that is when you often see bruising, right? So shins, totally normal. Shins were made for that. Forehead, totally normal. Right? So classic places are over those bony prominences. Fleshy places, not normal. Anything that's patterned. If you can pick a pattern out of a test question or on life, it ain't normal. Patterns, not normal. None of them. And then we'll talk about different burns and what those are going to look like. Fractures, if you have something that's unexplained, if you have any type of fracture in a non-ambulatory child, minus 2 types of birth fractures. What are those 2 types of birth fractures that could be considered normal?
Shoulder.
Clavicle and humerus.
Humerus.
Yep. I love you guys are just all like, we're at the point we're just pointing. Love it. Good. Star, highlight, underline this. High sensitivity for abuse. I need you to add the word posterior. So rib fractures are one thing. Posterior rib fractures, very, very high specificity. Okay? Not sensitivity, specificity. So a posterior rib fracture. The corner handle of a metaphyseal fracture. So if you have something where the edge of the bone, I'll show you a couple pictures later, the edge of the bone is coming apart on the metaphysis. It's usually from a jerking force, very quick jerking force. Scapular and vertebral fractures. How much force do you think that takes in a child?
A lot.
That's a lot of force. That's not normal for any type of play. I fell off the slide or a swing. That's not normal. Okay, so those, if you see a scapular, vertebral, metaphyseal, rib fracture, posterior rib fracture particularly, that should say, I know this question is asking about abuse, or I need to, this is abuse until proven otherwise in a clinical setting. Abdominal traumas, those ones are hard. The child has big toe bellies, giant bellies. They hold a lot of blood. So blunt traumas where you have injuries to really any abdomen can be very concerning. So things, if you have an acute abdomen on a baby or a toddler who can't talk to you and you don't have a mechanism of why, that should at least be on your radar as a differential. And then our head injuries, much like my patient who had that subdural hematoma, that subdural hemorrhage, it's going to be the leading cause of what's going to cause a child to die and have long-term morbidity. So this child that I was the provider for is the perfect example. There was not mortality, he did not die, but he had long-term morbidity where there was hearing loss and significant delays secondary to this. The typical things that you will see is that subdural hemorrhage from the shaking mechanism. It's not the intraparenchymal hemorrhage as much, although that can happen, but because the head is so big, you get those subdural bleeds, the retinal hemorrhages. So this line, those particular things, I know they're in small writing, but those particular things are very, very important. Retinal hemorrhage, subdural hematoma, and then those specificity of where your fractures are the things that you will need to know. This would be an example of something you would see. So this child comes in, this is a 3-month-old who's coming in with a tib fib fracture. What is already wrong about that? Yeah, the child's not old enough to ambulate. So that makes no sense of how you're getting a tib fib fracture. That's A. The middle picture is then when they did an entire bone scan. If you're looking at the bone scan, anywhere other than the bladder where it's concentrated, but anywhere where it's lighting up is showing that you had old fractures, right? So you're seeing, you can see some growth plates as well, but where other places you're seeing, the particular one I want you to focus in on, those posterior ribs. Okay, so you see those posterior ribs in B. So then they did something called a babygram. We'll talk about that in a minute, or a skeletal survey. We're taking pictures of different specific parts all over the baby, and they see multiple different fractures at different layers of healing. Followed up with that in 2 weeks, and you see calluses where those fractures are healing. So now you have different staged fractures. Okay, so this would be an example where you're seeing one thing, it didn't make sense. You follow that to its logical conclusion, and now you're starting to see this pattern of abuse. Not everything is abuse though, so things to remember. Slate gray nevi, we talked about that from the very beginning of pediatrics. I said we need to document this. If they come out with those slate gray macular, dermal melanocytosis was that other name for it, where that melanocytes got stuck in the dermal layer instead of the basal layer of the epidermis. So that's going to potentially look like bruising, and that's completely normal, so a big differential there. Is this a culture where they do cupping or coining, where those end up looking like little bruises, particularly on some of those fleshy parts? So is this something culturally that they were doing? Is there something from the newborn screen or from the familial history that indicates that there is a bleeding disorder? Things like those, or we haven't had that lecture yet. Sorry, that's block 3. Bleeding into your joints. What could be an indication they didn't get this as a newborn infant and now they're bleeding in their joints or in their head? What did they not get? Vitamin K. So was this a vitamin K deficient bleeding that maybe has nothing to do with abuse, but something that they didn't get as an infant? And then osteogenesis imperfecta. So very, very rare, but something that we do see where their bones are breaking because they don't have the correct structure for that. Behavioral indicators. So these children, a lot of times, are really wary to be around you. Most kids are really interactive and they'll play, or they'll go to their parents while they're kind of wary of you as the new person in the room. So these children very, very wary of adults, all adults most of the time. They're afraid to go home, they're afraid of their caregiver, they really don't want to interact. Inappropriate clothing for the weather. What does this typically look like? It's July in San Antonio, and these kids are wearing what? Long sleeves, hoodies, big baggy clothes where you really can't see anything. Yep. Moving uncomfortably. If you've seen children bound out of bed and off of exam tables and do like Spider-Man moves, you're like, how are you doing that? Right? That's how kids move. If you see a kid who's very gingerly getting off an exam table, and you can tell that you're like, well, that's not a normal way that a child moves, should be another indicator something's going on. Certainly the parents who are very controlling would be another indication. Your differential for your bruising. Most common, and this is what I really do want to stress, most of the time it's not abuse. So most of the time, your most likely differential is that this was a complete accident. So just keeping that, I know that after a bajillion slides, you're like, it's abuse. But most of the time in real life, this is just a complete accident. We talked about those dermatologic, the big one I want you to know is those slate gray nevi or dermal melanocytosis. Anything where heme is off, so later in the course we'll talk about ITP or idiopathic thrombocytic purpura. Is this a new onset leukemia where they really don't even have the ability to bleed or to clot, and they have this new onset bruising? Is this an infection? So is this sepsis and they're actually having DIC, or they're having a meningitis sepsis where you're seeing purpura on exam? Could be a lot of different things, but really the big takeaway is most often your bruising is really going to be from a total accident. What I want you to focus on this slide is the left-hand side of the slide. So the top part is where normal is. So normal over those bony prominences. You have a toddler that's bruising on their shins, bruising on their forehead, bruising kind of on the upper back part where they take a spill every time. Totally normal. Normal as it gets. You have a toddler that has bruising on the eye sockets, ears, neck, any kind of those fleshy parts, not normal. So the red at the bottom of the slide, not a normal pattern. So if you see bruising in those areas, I tell you there's bruising on the back of the arm. Where do you think that's from? Somebody pinching the back of the arm, right? So we'll look at a whole bunch of different pictures. So how do we use stages of bruising? Can we use this legally? Can we use this? When do we use stages of bruising? There is no great answer. Legally, you cannot use it as a provider. You can't say, it is the stage of bruising is yellow, therefore this happened on this day. Can't use that legally. What you can say is that you do know physiology. So you know in a bruise, you have this red blood cell with its hemoglobin that is breaking down into biliverdin and then into bilirubin. And that is going to go from a red, purple, all the way down to green, yellow, and then brown. And you know that that physiologic process takes a while. So if you have different bruising in multiple different colors, you can say that you have multiple different episodes. You can say that it's been over the course of days or weeks, depending on the colors of this. And you can say there's multiple different mechanisms that are causing this, or one mechanism that's repeatedly causing it. So those things with physiology you can say, because you know physiology, because you guys are so smart, so capable. So now you've been told it today. But you can't ever take a bruise and say, on this date and this time, I know that this happened. So that's kind of how you're kind of weaving that together. So be very careful with your documentation, what you do say and not say. Make sure it's grounded in physiology. This would be a good example of those various stages. You're seeing, number one, where's your location, right? Fleshy parts, buttocks, upper thigh, kind of in that tummy area. How many colors are you seeing? Several, right? You see some red, you see some purple, you see some brown, you see some kind of maybe a little yellowish color. So you're saying this is over areas that I shouldn't be seeing. There's multiple different times and multiple different colors. So I can say that from this picture. So this would be various stages of healing, multiple indications that this child had some sort of pattern concerning poor abuse. Unusual locations, so you should never see anything on the ear. Ear bruising is never normal. Even if you hit something, ear bruising, not normal. So the typical pattern is that a child is grabbed by the ear and then it's pulled and pulled up. So you see a pattern of kind of bruising in and around the ear, never normal. Ear bruising should make your suspicion go through the roof. I don't love this. The American Academy of Pediatrics really does. It seems easier just to remember what doesn't make sense. But 10-4 faces P. The big takeaway is that there really shouldn't be any facial bruising unless you're on that frontal forehead. So your frenulum should not just randomly bruise or bleed. You see that often if someone's trying to jam a bottle in, or a pacifier to make a child be quiet. Nothing of the angle of the mandible. Those are big, soft, sourdough-like places, so you shouldn't see anything on the ear, the cheek, the mandible, anything like that. Certainly in the eye socket, you shouldn't be seeing anything. My one beef is with the subconjunctival hemorrhages. So there's a couple of mechanisms that you do see this normally for kids. So birth trauma, you can see subconjunctival hemorrhages, and then a prolonged and really hard coughing. You see this in adults and children. So if they've had a really long cough, they've had, when we talk about it later, pertussis or RSV, that could be an indication where you might have that. And then the 4, and if they're not mobile, they shouldn't be able to be mobile in any way, shape, or form. They shouldn't have really any bruising. You should not have really any bruising under 4 months old. Those kind of the big takeaways for 10-4 faces. Patterns, good or bad?
Bad.
Bad. Patterns are bad. So anything where you are like, I can tell what that instrument is, no go. So it doesn't matter what it is. The amount of things that a family will come up with to abuse a child is really truly endless. So patterns, not okay. Again, if you can tell what it is, it's too hard. So what probably happened to the girl on the left?
Back.
Slap. You can see that that is a hand. So that pattern, that is too hard. That is not okay. On the other side, what's wrong with the place?
Fleshy.
Soft,
sucker.
fleshy place. How many colors?
Multiple.
A bunch. And then they say that your textbook says that this is a patterned bruise. Doesn't really as much look like a pattern to me, but this was a paddle that was used for this child. This one, the child had a necklace, and so the necklace was used to pull the child up by their neck. So again, you can see that there's a pattern. So I can tell you by just there being a pattern, that was not normal. So pattern bruise where you can see something, not going to be normal. The double cord is really if you take any kind of extension cord and that is used in a whipping pattern. So that whipping pattern, anything where you can see is not going to be normal. So all those different places, that's the back of the arm, the side, the back, not ever normal for that. And that double corded pattern on those fleshy places. You have two things wrong. I'm seeing patterns, I'm seeing different colors, and I see different in the wrong areas. A couple more pictures and we'll take a break here in a second. So when you do see some ligature things, so this was a baby that was tied to its crib. So the baby was tied by its neck, so there's a ligature mark on the neck. That's never ever normal. The other one, this baby was tied to the crib with the wrists. So it created this ligature pattern around the wrist. So distal perfusion was lost as well. So not ever normal. Last one, and then we'll take this break. So, bite marks. What caused the one on that top left?
Dog.
Dog. How can you tell it was a dog? Kind of ripping, tearing. What about the right, top right?
Cat.
Cat. How can you tell?
Puncture.
Puncture. What about the bottom one?
Human.
Human. How can you tell?
Top and bottom.
You kind of have the whole rounded inside mark there. So, that is it. So, yeah, take about 10 minutes, and then we'll come back at 1:53. See burns. When we're moving over into burns, again, pattern is one of the biggest things that we look at. So anytime that you see a pattern, if you can tell what it is from the burn, that is concerning. So just in general. So we'll look at a couple of those. And part of that means immersion. So immersion itself is a patterned burn. Okay, so those sometimes that was a hard one for me to put into my head, but an immersion has a specific pattern that you are going to see with this we'll talk about. So when we're looking at immersion type burns, it's usually where somebody is holding a child's hand, foot, or part of their body in water. A couple of things you see. One, you think to yourself, ooh, maybe I should have done that newborn prevention where I told them to not keep the water more than this amount of degrees. What was that number of degrees? 120. Yes, no one will miss that on your board exam. But the thing that children will do, humans actually, but particularly children, the instinctive pattern, if you are being submerged into something hot, is extension or flexion?
Flexion.
Flexion, correct. So you will see flexural creases that are trying to be spared. So that is going to be one of the patterns you see. So on that far left-hand side, when that child was placed in fluid, trying to flex up into that, so you see part of that abdomen and part of that are spared, right? That flexural crease with the burn. The part of immersion patterns also is going to be circumferential. So when you hear stocking glove or glove pattern, stocking the foot, glove pattern being the whole hand that was submerged. And then from the far right hand side, that's when you see that if a child was set into something and they're trying to flex their legs up to stay away from that. So you see more of the bottom of the leg burned before you will see it go circumferentially up the body. So immersion patterns, never normal. What is normal is this very weird picture of how kids actually work. So children, if you give them something that they can pull or touch or grab, they will. So I think the most common burn that I've ever seen is ramen noodles or something right out of the microwave. So if there is a cord that they can pull from a crock pot, from an Instapot, from a rice cooker, anything like that, you're going to see this kind of splash pattern. So it's very different than an immersive pattern. That most of the time is an accident. The middle thing that you're seeing is what pediatricians hate. We really hate these walkers, right? The walkers give children developmental skills that otherwise they wouldn't have. So you have a kid that in a walker can move and get to all these different places and reach things that otherwise they wouldn't be able to. So that times you do get some immersion-like patterns because if it is being pulled into their lap, again, flexural creases are spared, but developmentally that doesn't make sense. And then compare that to a child that is held underwater can be concerning for that immersion pattern. Again, immersion all the way under, circumferential or out the legs. The child is being set in the water, flexural creases. Immersion pattern, stocking glove. This would be the accidental burn. So you see no immersion pattern. You see that the toes are spared. And you see this a splash. So that splash and blistering pattern, that's a very normal and accidental pattern. So accidental burns do happen. Again, that's going to be one of your highest things on your differential. Very accidental when you see none of those pattern things. What about this? Do you think this is an accident or not?
Maybe.
No. Does there
Fits
look
the
like there's a
walker?
pattern?
Yeah.
Yes. Does it look like an appropriate place for a burn? No. So this child was crying and was set on top of a radiator grill until they stopped crying.
Oh.
So that is not a normal burn, not a normal pattern, no way, shape, or form.
I thought they were in a walker.
What does that look like?
Oven?
Curling iron, yeah. Is that normal to see? What happens most of the time if a curling iron hit something? Pull it away really quickly. You wouldn't see that it left a deep pattern mark. What about these? Circumferential small little circles here. Cigarette patterns. Normal? Never normal. A patterned thing that you're seeing. Never normal. Differential, most common, accident. So burns happen all the time. Kids will burn themselves on hot chocolate, on ramen, on soup, it doesn't matter. The kids will burn themselves. It just happens. They love to touch hot stoves, hot curling irons. If they can find it, they will do it. The most common thing is going to be it's completely accidental. Other things, this could be truly infectious. You have a scalded skin syndrome or an impetigo. Certainly that would probably be more on the face, but you could see it diffusely everywhere. Some other dermatologic skin. So we've got more in that derm. That is, do you have an SDS? Do you have a severe diaper dermatitis, a leukocyte adhesion disorder, any kind of things, an epidermolysis? You can see all kinds of different things. And then again, the cultural practices. I had never heard of moxibustion. Has anyone ever heard of that before? It's a really interesting kind of oriental pattern where it's a mugwort. And they will burn the mugwort while it's sitting on someone's skin. And so it's supposed to heat up the skin and bring healing to right where that area is, but you can see how that could go awry. And so potentially there are some cultural things and cultural practices going on to put into consideration. What about fractures? What are the classic fractures that you've heard about being abusive patterns? Or spiral, why?
Twisting.
There's some sort of twisting motion, correct. Where were those places that were high specificity for?
Posterior ribs.
Posterior ribs, scapula,
Tib fib.
not necessarily vertebral, or vertebral, not necessarily.
Vertebral.
Yeah. And then the tapezial fractures. Talk about a couple other ones. So you guys got it. So super suspicious if it is a spiral fracture. The caveat that I will give to this is the most spiral fractures that I have ever seen, and you could probably ask almost any pediatrician, is from kids with their parents going down a slide. Totally accidentally. You put the child on the lap, the kid's legs get stuck under the parents, and you end up with a spiral fracture. So beware of slides. Ask the parents if you see a spiral fracture what they were doing that day. If they say we were at the playground, what were you doing on the playground? Most of the time the parents will come in feeling terrible. Don't make them feel worse. The metaphyseal, we'll show you a picture. It looks like a bucket handle. This is not a buccal fracture. This is a buccal handle fracture, so two different things. Don't mess those ones up. Again, you guys already got it. Highly unlikely places that you would see. I would add sternal fractures to that list. I've never seen a sternal fracture that was outside of an MVA. So certainly if they had a mechanism that where there was a trauma and everyone was part of that, that makes sense. And then non-linear skull fractures. So again, kids will do the craziest things. It was another pediatrician friend, their kid, they got into a shopping cart basket, the kid was learning to walk, stood up in the shopping cart, their big giant head fell to the ground, linear skull fracture, happened in about 2 seconds, right? Those type of accidents happen all the time. What you don't expect to see is non-linear skull fractures. That usually means some sort of blunt force was used and it's kind of shattering the bone as opposed to one mechanism of a hit. And then the skeletal surveys, that's what I was talking about a little bit earlier. So if you are suspicious that you see some type of fracture and you have a child who cannot talk to you, so it's functionally like vet medicine, right? You're trying to figure out what's going on with this 2-year-old who can't really tell you everything. You'll do a skeletal survey, and that is a series of about 30 different x-rays that are going in detail in different parts of this body for the child to really give you a good look at all the different full body scans. Most likely differential for a fracture, an accident, so there should be a pattern here. Yes?
For the skeletal surveys, wouldn't you have had the parents' consent for that, or?
It depends. So if parents consent most of the time, if there is a high level of concern for abuse where you are going to admit that child and they are not going home and CPS takes over, then you end up with implied consent or state takes consent. So yes, and a complicated answer. Good question. Pattern here being most of the time your differential is going to be an accidental. We already talked about the birth trauma that you can see. Is this an osteogenesis time? A copper deficiency. So most of the time we talk about when there's too much copper. What's that disease called? Wilson's. Yep. So, but you could have a copper deficiency. That congenital syphilis and torches infections will get you. And then is it an infection? So something else going on. But most of the time, again, highlight that injury is the most common. Spiral fractures, you guys already got it, that twisting motion. Most of the time is going to be inappropriate. Are instances where it can be appropriate. And this is where that bucket handle is. I always want to call it buckle fracture. That's why I'm like, don't do what I'm doing. So bucket handle fracture is really if somebody is jerked. So an arm or a leg is pulled or jerked. So that kind of corner of the metaphysis comes off. That's not normal. You don't typically see that. And it's really the exact opposite of a buckle fracture. Buckle is just buckling under that pressure. This is being jerked off with the corner handle of a bucket. Not normal. Very high specificity for abuse. Scapular fracture, not normal. Too much force. Way too much weird mechanisms that you don't typically see, especially posterior mechanisms. Same as bruising, so this is going to be a very similar pattern. You can't say that on this date and time this did or did not happen, but if you see multiple fractures in multiple stages of healing, you can comment on that. Physiologically, you know what's going to happen. There will be a line, you'll see the fracture line, and you'll see some periosteal bone formation, you'll see a callus, you'll see the callus becoming more dense, and all those have rough timelines. So if you see a new fracture, plus you see some early callus forming, plus you see a dense callus forming, well now you know there's been 3 different time frames where something has happened to this child. And you can confidently say multiple fractures in multiple areas in different stages of healing. And that is what is concerning for abuse. That is what you can say. This would be different examples. I think the one on the left is again another example where you see that posterior rib fracture, where you see that joint space right next to the vertebral body has that callus formation in that posterior rib, never normal. I think that one's a little bit harder to see than the right side, where you're seeing new fracture lines in some of them. So this middle one, kind of a new fracture line, the new periosteal bone, and then that top one is looking at that denser callus formation. So you're seeing 3 different stages of healing in an area where you don't really even expect a kid to have. You might see 1 fracture that's normal, really not 3 while they're acutely healing. Abusive head trauma. So shaken baby. So please star this one, because this is what you really see the most morbidity and mortality from. Certainly we never want a child to be harmed or hurt, but these are the things that are going to kill a child. So that force back and forth is going to cause 3 different things to happen. 1, your subdural hematoma. So that's what your most common thing. You might see other things, but your most common, your go-to for clinical and pants things are going to be your subdural hematoma. Your retinal hemorrhages. So how many of you feel super comfortable with the ophthalmoscope down in Brooklyn? Not at all, right? Not very few of us. So if you're in an ER setting and you're the provider and you're like, I'm not confident, I'm gonna try to take a look, looking for retinal hemorrhages, bleeding behind that eye, but who else am I gonna consult to see?
Opto.
Yeah, opto. So that should be part of thinking, this is part of my child abuse workup, is to have opto come and do a retinal exam. And then swelling. So you're gonna see in general cerebral edema. So this would be an example in that posterior section where you have, I just learned about this pointer last semester and I've really been liking it. But it doesn't work for me. So you have that posterior subdural hematoma, not normal in a kid, but particularly not normal in a baby. Retinal hemorrhages, none of us are typically in the primary care world awesome at this, unless you've had a lot of practice in an ER setting or with optometry or ophthalmology. But you can tell that this isn't normal. You can see that there's normal vessels kind of converging into one central location like they should be, and now you just kind of have this lake or this over here of bleeding into the back posterior portion of the retina. Not normal. And you don't have to be awesome at an ophthalmoscope to say that looks like there's bleeding and that looks not normal. That's enough for you to say I have severe suspicions that there was some sort of abusive head trauma to this child based on there being bleeding on the retina. Most likely differential accident. First thing, again, was this the child of the pediatrician that stood up in the basket at Target and fell out? Most likely. So your most likely differential is this going to be accidental. Vitamin K deficiency, going back to that birth history. Are they newborn? Is this something that we would expect to be seeing potentially? Is this hemophilia? So hemophilia, I know you guys haven't had hemonc yet, but you've talked about it maybe in other classes. Males or females?
Females?
Males, why? It's an X-linked disorder. So if somebody is trying to tell you that their 3-month-old daughter has hemophilia, and you have normal newborn screens, you should think twice.
Think of the British,
Does that make sense? No.
royal family
Things
has
like that.
hemophilia as like the queen.
Few words on sexual abuse. I think a lot of things that we will see most of the time are going to be reported that there is females. Most of the time there is an underreporting in males that we do see. The disclosures, a lot of times you don't see for days, weeks, months, years. You see adults who are, something is happening in their life and they're just then starting to come to grips with kind of what happened to them. The biggest clinical presentation, if you see a couple of things. So recurrent UTIs. Number 1 cause of UTIs in the child is going to be chronic constipation. We have a whole lecture for GI, but chronic constipation, number 1 thing. Number 2 thing is going to be hygiene concerns, particularly for who? Little boys or little girls?
Girls.
Little girls, yep. Number 3 is going to be anatomical variability or abnormalities. Something in the anatomy is not right. Okay? If you've ruled those 3 things out and addressed all of those 3 things and they're still getting recurrent UTIs, high suspicion for abuse. So, sexually transmitted infections, particularly in your pre-pubertal kids. Never going to be normal for a 6-year-old to have gonorrhea. No way, shape, or form is that going to be normal. The one exception would be that you will sometimes see a child auto-inoculate themselves with warts. So that one you're going to have to use your provider brain to really kind of tease that apart. But that can be a variant of normal. But GC, chlamydia, HIV, if we've tested the moms and babies, never gonna be normal for that. The behavioral indicators are probably where you're gonna pick this up more often. So advanced sexual knowledge. So you will often hear this from teachers and parents that will come to you as the provider and say, the 5-year-old is telling all of the other kids all kinds of things in kindergarten. So that should be a red flag for you as a provider. How does the 5-year-old know the ins and outs of how things are working? That's not a normal amount of information. Promiscuity, so if you see little kids acting very promiscuous, particularly with other kids. So we're talking 7, 8, 9, pre-pubertal that are starting to act on some of these things, that tells you there's an advanced sexual knowledge. That should be another red flag for you. Sudden school difficulties, I usually will say sudden changes wherever it is. I used to love soccer. Suddenly, I don't like soccer anymore. I was an A+ student. Suddenly, I'm failing all of my grades. I used to love going to youth group. Now I really hate it. I don't want to go there anymore. If there's something where there's a sudden change, that should just be a behavioral indicator that something has changed there and is coming up. So it should be some part of your history and your differential. The other ones I would also put in that kind of category that oftentimes with sexual abuse, these are relatively sudden. So is there a sudden depression and change in their affect? Sudden anxiety, sudden nightmares, avoiding of specific places very suddenly. That should be an indicator something changed and to get a significant history for that. Your physical exam findings can be quite pronounced or could be nothing. Particularly if it's after that 72-hour mark. So a lot of times completely normal exams. So certainly abnormal would be if you saw any kind of STIs or trauma on exam. That trauma is going to be typically within the last couple of days and needs to have a specific examination. So I don't know, you haven't had intimate partner violence yet, but there's SANE nurses. So sexual assault nurse examiners have specific training for sexual assault. P-SANE nurses are the pediatric ones. And so wherever you are, if you're a provider, knowing where's my SANE nurse, so BAMC has a SANE nurse, where's my P-SANE nurse? So for all of San Antonio, the P-SANE nurses are at CHOSA, right? So if you show up anywhere and you need a sexual assault examination, you're gonna go down to CHOSA as a child, knowing where your resources are. But if it's burns, all burns go to UT for kids. So when you're a provider, knowing what's in your area and what you need to do to get kids to particular places. And those will be the ones that will take your specific kits and do the specific trauma exams for kiddos. So don't worry, you're not gonna have to do trauma exams in kids. I can't think of a time where you would ever have to do that. Quick word on emotional abuse. Sometimes that presentation is really where you have a mismatch in bonding, so the parents and the child is really showing no kind of connection, some sort of low self-esteem that is presenting a lot of times in school performance, and social isolation, something that kind of doesn't make sense for that. Somatic complaints, if you have a child where everything is normal when you're doing labs and evaluations and examinations, but they're having recurrent somatic complaints, that's not really normal. It's not normal for an 8-year-old to have repetitive somatic complaints outside of something else going on. And then, come on, physical exam, you can see that again with failure to thrive. Is this more of an emotional piece of this going on, or very untrusting of what the situation is because they're not in a safe environment? Some of those indicators, again, that would be with some of those isolation. So it's just a kid who has new habits that are forming, or something that maybe can be considered a little bit on the odd side. So destructive behaviors you can also see sometimes. Are they delayed? So were they not getting that emotional connection from a parent? And so some of their developmental milestones are delayed. So again, hint for the test on Friday, you're going to need to know all of those normal developmental milestones from those earlier lectures. And then extreme behaviors. So sometimes if they've been abused, they now become the bully. So do you have situations where they are getting bullied or they are becoming the bully, or two things happening at the same time? So a detailed history is going to help tease that apart. Okay, now that you are mandated reporters, right? How do I report this abuse? Do I need to report everything? What am I doing? What is going on here? So what does it mean to have reasonable suspicion? And the best kind of definition is, would a normal person with the information and education that you have also think that this had suspicion or concern? Right? That's kind of the standard that you're held to for a standard of care review. So if you have reasonable suspicion, there's not a great legal definition unless we've changed something about what reasonable suspicion is, but if there is something going on in your brain where you're like, this isn't right, I have reasonable suspicion, and I think my other PA counterparts would think that as well, that is enough to go ahead and mandate, or be a mandated reporter and send a report in. Does not require certainty. You are not the investigator, you are reporting suspicion. I usually kind of will operate on 3 strikes, you're out. So if there's 3 things that make my provider flag go up, I usually am taking that into account. So certainly in the cases of abuse, there could just be one significant something, but if I start to get that spidey sense as a provider and the history is not adding up, there's something weird on exam, the child's affect maybe, so there's 3 different things, 3 strikes you're out is kind of the rule that I typically will practice by. Again, not your job to investigate, you are just the reporter. However, it's worse when you fail to report. So potentially, there are cases, state by state, where this could even be something that is on your license. So if you put in your notes, I'm concerned for abuse, and then didn't report, that could come back to you as the provider. So if you think it, either clearly document why you're not reporting and why that makes sense, or go ahead and send a report in. This is a child welfare information gateway, so every state is going to have slightly different ways that they call CPS. So it might not be Child Protective Services. My last base, it was called CYFD, so it was Child's Family and Youth Department. Okay, so every state is going to have slightly different. Can you make an online report? Do you have to call in? Can you do anonymous reporting? So every state will have slightly different mandated reporting. The military has mandated reporting as well. So depending on your branch and what some of those avenues are, if there's active duty members involved, that can be something that is reported through the military as well. Thorough histories, again, those assault exams, the PSANE nurses, if you need those. Family advocacy, so Dr. Hatch will talk probably a little bit more about that in a minute. If you have that spidey sense where this child is not safe to go home at all, that would be an indication for admission. So to your point of, do you have to get the parent's consent? If you really truly think there is a safety concern and this child is not safe to go home, you can admit. That flowchart gets you to the same place. So if you like to study with flowcharts instead, I'm going to get you down into that very similar thing. So a couple of things. What are some red flags for abuse?
Patterns.
Patterns. Any kind of pattern, burn, bruising, something where you're seeing that pattern. Good. What else?
Fractures in non-mobile children.
Inconsistent stories.
Fractures in non-mobile children.
Fractures in non-mobile children. What else in non-mobile children?
Bruises.
Bruising, non-mobile children. What kind of patterns of bruising? Where would you expect to see bruising? Shins. Where else? Kind of over bony prominences, forehead. Where do you not expect to see bruising?
Soft, doughy
Soft
areas.
spots. Sourdough-like things. Interview strategies if you suspect abuse.
Get them alone.
Get a chaperone for yourself and them. Yep. What else? Don't confront them. Don't show frustration. How else?
Don't blame them.
Don't blame them. Are you the investigator?
No.
No, you're just a reporter. Long-term complications of abuse in children. Depression.
Failure to thrive.
Would be a more aggressive adult.
Failure to thrive. Failure to thrive.
Failure to thrive, sure. Developmentally, interpersonal relationships, sure. Characteristic findings associated with abuse. That's a terrible question. I don't know why I wrote that. I'm so sorry. It's so broad. You guys listed off a lot of those. So I know it's really hot in here. Take 10, and then we'll be back at 1:30, and Dr. Hatch has about 20 minutes.